we're really excited to have Tom Keane here in the studios. He is a former colleague of mine and the Assistant Secretary for Technology Policy. Tom Keane, welcome to AFPI.
Thank you so much for having me.
Well, we're excited to talk to you today. We were enjoying some real wonky talk out in the green room, so it's good to have you here to talk about some of the really substantive policies that HHS, along with RFK and the rest of the team, are working on to make to MAHA, to make all of us healthy again and really give us the tools we need to be healthy. So, Tom, first, not a lot of people know what the Assistant Secretary for Technology Policy does. So what is it what you do over at HHS?
So the Assistant Secretary for Technology Policy administers all of the HHS's policies regarding health information technology.
Okay.
We issue regulations that regulate healthcare IT, that regulate electronic health records, and a big part of our role is to coordinate among players in the health tech ecosystem so that health technology talks to each other, so that it works for physicians and patients and nurses. And we also have a role in standing up networks so that these technologies work with each other and operate together so that people can get their health information when and where they need it.
And that sounds, again, like a huge job, a huge task, especially since, pulling out my phone, I do a lot of my healthcare on my cell phone. Mm-hmm. So, tactically speaking, what all, I have my health records in my phone. Is that something that you do over at ASTP?
It is. So, for example, in order to get electronic health records that hold your health information to communicate with your phone, there has to be a standard, a data exchange standard that allows data to get from the electronic health record to your phone. And we administer those standards. We help fund their development. We work with the agencies that develop it, the private standard development organizations, and then we adopt those standards into our regulation that require health IT developers to adopt those standards. And that's why you're able to so easily download your electronic health record information to your phone and to your Apple, your Apple
my Apple Health app mm-hmm. and my Function app, my mm-hmm. Whoop, I'm double deviced up. I've got mm-hmm. the Whoop and the Oura Ring, and they all talk to my phone, and they all actually talk to each other. Mm-hmm. And so you're the guy to thank for that.
You can thank the agency for it. It's been
I'm going to thank you, Tom.
Well,
Don't worry about
I'll
it.
Take it.
But that's great because that's all the infrastructure that's behind some of the most complex things that you and I, we don't think about on the day-to-day as the mm-hmm. healthcare consumer. I just know mm-hmm. it's easy. Mm-hmm. And so I think, one of the challenges I think for y'all have been really getting all of these different either apps or my doctor's offices mm-hmm. to really talk to each other when they have all of my health records so that, Dr. A knows that, Dr. B, what they're doing and how to exchange that.
And a lot of this has to be voluntary, and it has to be something that works for the entire ecosystem. It has to work for government. It has to work for health app developers, like the folks who make applications for your phone. And it has to work for major hospitals and mm-hmm. the EHR developers that support those hospitals. And so a big part of our role is to coordinate these people, to bring them all together, to convene them, and to have a process for convening them and a process to help them develop standards. Back in the 70s, they started rolling out cellular phone networks. And getting cellular phone networks to talk to individual phone handsets was a big undertaking. The first cell phone tower was built in Chicago, where I'm from, in 1978, but it was nearly 17 years later in the mid-90s when cell phones started to really be commercialized.
Wow.
And then, of course, by the mid-2000s, everybody had a cell phone in their pocket. What we've been able to do, because government has taken an active role in developing and promulgating these standards, is we've gotten people to adopt interoperability much more quickly than in other networking applications.
Which again is just, really, I was always so impressed by the work of folks like you at HHS who were able to, again, this seems like very dry to anyone else, but really it's about cracking heads together and saying, for the love of God, y'all have to have systems that actually can communicate, or else Hannah is not going to be able to use a Function app or something like that. So,
well, I'm glad to say that because of the way we approach, which is getting people to cooperate and coordinate. I haven't had to crack heads yet, but I'm not unamenable to the idea.
And you're going to do it if it's going to make things easier for people.
Absolutely.
Well, and that brings me to really what I was speechless when HHS put out a really, I don't know, it was almost like a benign press release. Hey, we changed standard XYZ. And this will now allow, patients and doctors to know the price of the medication as they're sitting in the doctor's office. I was almost knocked out of my chair.
Yeah.
This is something that House Republicans and Senate Republicans have been trying to do. This is something that I'm sure, the administration fiddled around with the last time. But this was groundbreaking work. So can you tell us a little bit about, this was huge price transparency work that y'all were able just to roll out and say, you know what, this is what American patients need.
It really, it was a big step forward. At HHS, we have the ability to issue regulations that apply to electronic health IT developers, and we have the ability to issue regulations that apply to health insurance plans. And so in coordination with our colleagues at CMS, we've issued regulations that say the prices that the insurance companies will ultimately ask a patient to pay as part of their copay or their patient out-of-pocket expense has to be reported to the doctor's office in real time. And we call this the real-time pharmacy benefit application. So what happens as this application goes live is when a doctor is looking at his electronic health record and deciding what to prescribe patients, he can not only look at different sorts of therapies, say, for example, for high blood pressure, but he can also see that for this particular patient, these particular therapies at these particular pharmacies have a particular cost. So if there's 4 or 5 drugs that will work equally well for a patient, he or she, the physician, will choose the cheapest. Yes.
Because I know you and I both, I'm sure, have been sitting in the doctor's office, and the doctor's like, okay, I'm going to prescribe you the drug. Where do you want it sent? And you're like, oh my God, I don't know. The CVS down the street, I guess that's fine, or the whatever pharmacy that's close. But finally being able to know that my prescription, which might be $20 at the CVS, $10 at the Walgreens, and maybe $5 at the super local pharmacy, and being able to actually see the difference in price, that's huge because that's savings, real savings for the patient.
Correct. And the physician can not only advise the patient on what the best channel, the best pharmacy to pick up the drug at is, but which drug to use. And they've found is that this has been deployed. About 1 out of 8 prescriptions are changed by the doctor so that they can choose the lowest cost alternative for the patient. And they've also found that there's been about a 10 to 15% drop-off in what's called patient abandonment. Wow. And this is the circumstance where you show up at the pharmacy and you find out that your out-of-pocket cost is so high that you don't pick up the drug. And this means improved patient care, improved patient experience, and frankly, less burden on physicians who would oftentimes have to have a second appointment with the patient to choose a different drug.
That's incredible. And again, this is the kind of reforms that the Trump administration is taking, from RFK Jr. to President Trump negotiating the price of drugs, really looking for ways to help the patient and really put the patient first and to become healthier. So, it's stuff like this, again. When I was at the department, it's the common sense ideas that you're just amazed that hadn't ever gotten done before.
And I think Secretary Kennedy's approach is to really focus on the patient. As much as you have to focus on the system and all of the players in the system, if you put the patient at the center of your policy making, the patient experience, the patient well-being, you really get the best outcomes. This is part of the reason that Secretary Kennedy is focusing on chronic disease and the chronic disease epidemic. We can't address the issues of American healthcare costs or the issue of American health in general unless we focus on the chronic disease epidemic.
And again, just like tremendous work. And I know when I was with the secretary in Argentina, we're sitting around a table talking about our efforts to really modernize the system. And there were several moments where he turned back at me and he said, hey, Hannah, why aren't we doing this? And I was like, the regulations. And so, this is the first step that y'all are taking to really, again, modernize and make things easier for people and cutting through the regulations to get people what they need, the information they need. So that's incredible. So, I mean, if this is just step one, I mean, what's the next step for you? What else are you working on over at ASTP?
Well, a number of things. First off, one of the great challenges that physicians and patients face is the burden of prior authorization. This is where you'd like to have a procedure or particular medical therapy, and the insurance company has to sign off on it first. And the process of getting the insurance company to sign off on it involves multiple points of communication between the doctor's office, the patient, and the insurance company, which can delay care and oftentimes be burdensome. This can all be automated in the era of modern computers.
Yeah.
And so in this same rule in which we adopted the real-time pharmacy benefit determination, we also adopted rules related to prior authorization to make prior authorization happen electronically. Our goal is that by January 1st, 2027, at least 80% of prior authorizations will be adjudicated at the point of care in real time. So
Amazing.
that when you walk into the doctor's office and you say, hey, I need surgery on my knee, the doctor can simply press a button and say it's approved by your insurance company.
And I love that because you know what they're using right now for prior authorization?
Don't say it. I know.
Fax machines.
Fax machines, yes.
And so we still have our poor doctors using fax machines for all sorts of, hey, can Hannah get this procedure? Can Tom get this procedure?
This is a mid-1980s technology that forms the backbone of communication between doctors and health plans, and we aim to change that.
And you know what I did to poor Secretary Kennedy?
What did you do?
I tried to make him defend fax machines in Argentina, and it was a futile effort. So.
Well, but the great thing about the Secretary is he's able to take in the information that he sees. He sees something great working in South America, and he brings it back to the U.S., and he makes sure that it happens.
So, and I think, you know, one thing that I think would be important for folks to understand is we've got people like Tom, who's in there cracking skulls, very nice man, so, you know, he's nicely cracking skulls. Really making sure and holding people accountable and industry accountable to get the American people what they need to make good healthcare choices. Pull kind of the curtains open and give people a little bit of an understanding of how challenging it is sometimes to kind of get the regulated industry to the point where they're saying, oh, you know what, actually it's not that difficult.
Mm-hmm. Well, our approach, we were formerly called the Office of the National Coordinator for Health IT. And coordination is an important part of what we do. And what we find is that as we establish long-term relationships with health plans, with physicians and providers, with electronic health record companies, with health tech app developers, that these relationships can be leveraged to get everybody on the same page. It is a little bit like herding cats. But what we find is, for the most part, folks want to do the right thing. It's just that they have differences of opinion about how to get there. And our role is to provide a glide path for getting to yes.
It's amazing.
And we've been, the organization has been in existence now for, I believe, 21 years, and we have a large pool of capital, of relationship capital and of credibility with these organizations, and that's why we're able to get these things done.
And so again, I won't ask for too many details here, but I know every health policy nerd, such as myself, always is like waiting for the day where my health record is fully portable. Just yes or no, is this something you're working on?
It is something that we're working on, and it is a top priority for the Secretary. I believe the Secretary, and you can correct me if I'm wrong, was in Indonesia, and he was able to see that people in Indonesia were able to get their health records on their phone, and that this was a nationwide policy. Now, in these more socialized systems, that's easy to do because the government controls all of your health records and has them all in one location. In the United States, we believe in free markets, and we have a federated system where you can go to Georgetown, you can go to George Washington, you can go to any hospital or any doctor that you want. Scooping up these health records and bringing them onto your phone is both a technologically challenging problem and also a policy challenging problem because it requires trust. We believe that health records need to be safe and secure, and that they should only be available to the patient with the patient's consent. So we are working very aggressively on getting patients individual access to their health records on their phone. We are standing up the technological policies as well as the policy agreements among the players in the ecosystem to make this happen. And we've also stood up a nationwide network that was instantiated in statute called TEFCA.
Yep.
And it wouldn't be government if there wasn't a acronym.
It sure wouldn't.
TEFCA stands for the Trust Exchange Framework and Common Agreement, which I expect everybody to be able to memorize.
Memorized, yeah.
This is a nationwide network that's currently operating that allows people to grab their individual health information from all of the different sites where it's held. It's grown rapidly under Secretary Kennedy. When he took office in January, there were about 10 million health records that had been exchanged on it.
Wow.
Right now, as of today, 11 months later, there have been about 120 million health records exchanged on it in a very short period of time.
And just showing that you can have innovation in technology, you can protect people's privacy, and you can, again, improve people's health and put all of that under one umbrella. And, again, when I was on the Hill and we were working on PBM transparency, one of the issues that we constantly butted up into was the privacy issue. Can we make sure that as we're exchanging claims information, so all those information that you get in prices and price transparency that we talk a lot about at AFPI, are you transferring that in a way that's going to protect, what if I have an embarrassing health condition that my employer might want to take, some sort of retaliatory action against me? Can we make sure that patients are protected from that?
100%. The HIPAA law of 1996 did two things. It allowed patients an individual right of access to their own health records. Prior to that, believe it or not, a doctor could refuse to give you access to your own health records. That all changed in 1996.
That's insane.
The other thing that the 1996 law did was guarantee the privacy and security of these health records. And it's taken very seriously by hospitals and physicians. I know as a practicing physician, I never talk about my patients.
No.
I never share their records, and I make sure that all of their records are secure unless they give me consent. The wonderful thing about modern technology is all of these policies can be instantiated in the modern technology that we have. So you can really be assured under the networks that we're standing up that your data is safe and secure, and that it is a priority of our architecting the network to allow for sharing with the patient's consent, but to make sure that the data doesn't go to anybody who isn't supposed to have it, including an employer who might take prejudicial action against you, or anybody else. And this is true whether you have a private health condition or no health condition at all.
And that is just, again, one of the things that I think y'all are facing, not just theoretically, but really trying to work out the details of, as we see the administration really supporting wearables. I love these little things. These things tell me so much about the day-to-day activities, my day-to-day health. I know that y'all are pushing out a program to get more seniors on board with knowing, some people say VO2 max is a vital. Can we make sure that we're understanding seniors' VO2 max through the wearables? But getting this data right now to my doctor is really difficult. I actually downloaded in a very obnoxious stream of PDFs and sent it over email to my doctor. And that, to me, I had, again, as a health policy nerd, I said, is this more secure than, what could be happening behind the scenes where there is a secure channel to send it through? Because really at that point, to get the information off my Whoop to send to my doctor, it was screenshots and sending it over an unsecure
Well, that
email
sounds
channel.
pretty insecure. We are working on getting information from wearables over to doctors and into the electronic health record. Right now, for example, if you have an implantable cardio defibrillator, that defibrillator actually communicates with the company that manufactures it through your phone. So it continuously monitors your heart rhythm. If it has to give you a shock, it records that and reports it through the phone. Interestingly, some people can be shocked by these devices and not even know it because they're unconscious when the shock happens.
Oh, boy.
So it's very important that this device information be communicated back to the doctor. Right now it happens through the company itself. The device uses your phone to communicate to the company, and the company communicates to the doctor. While this certainly works, it is less efficient than the system that we're hoping to put in place. So in the coming months, probably sometime in the spring or the summer, we're going to be proposing new regulations to help these devices communicate safely and securely with electronic health records and with your doctor.
So, final question, and thank you so much for your generosity and your time, is if you could wave your magic wand outside of the area that you regulate, what would you change about the U.S. health system?
That's a real on-the-spot question.
I know, I'm putting you on the hot seat.
What would I change about the U.S. health system? I would certainly make it more affordable for the average patient. You know, most of us in our day-to-day lives make decisions based on what resources we have available, what time resources we have available, what financial resources we have available. And if this means that we're going to take a vacation that's a drive away, we do it. This means that if we want to take up a hobby but we don't have time because we have responsibilities with our children, we don't do it. Unfortunately, we don't have perfect control over our health. Nobody chooses to get sick. And unfortunately, now when people get sick, they have to worry not only about how much time they have to manage the normal activities of their life, they have to wonder, is this going to bankrupt me? Is this going to tax my financial resources? I would love to see the healthcare system become more affordable so that the average American doesn't have to worry when they get sick, not only about being sick, but also about facing financial hardship. So that's the one thing I would change.
I think that's a great answer. And you know, President Trump and Bobby Kennedy and you all and the rest of the team at HHS are doing a great job to achieve that. So thank you for your work there, and appreciate you coming to AFPI today.
And thank you for having me.
Oh, it's my pleasure. Thank you guys, and really appreciate you coming on.